My name's Rick Gardner, Dr. Rick here. I'm the medical director of Cure Ethiopia Children's Hospital. I've been here for 6 years. I'm an orthopedic surgeon, and my main role here is to care for children with physical disability. From the UK, I spent time working in other Cure hospitals over the years. I spent time working in Malawi and with other organisations overseas, but my primary training was in the UK. I did a fellowship at the Hospital for Sick Children in Canada, and then the other time with Cure in Malawi really gave me the experience to take care of these children the very best way. So Cure Ethiopia Children's Hospital is a charitable hospital. We have children coming from all over the country. They travel for many days sometimes. Some of them are local, but many travel for days to reach us. And they have a whole range of challenges to deal with, both for the upper limb and for the lower limb. Children who are considered disabled within their communities. They may have club foot. They may have a limb that is much shorter on one side. They may have a very stiff joint or a joint that is dislocated. One of the primary conditions we deal with are children born with dislocated hips. Surprisingly, it's a huge issue in Ethiopia. It has been thought to be very rare in Africa, but we know that in Ethiopia it's extremely common. It's particularly common around Addis Ababa, and one of our huge challenges is to treat children at an age where they're young enough to be managed without surgery. The main issue that we have is the children come along at walking age. They're coming along at age 2, 3, 4, all the way through until adulthood, where they're walking with a limp, and it's often a member of the family who's saying, little Tigris is walking with a limp, and should be seen. And then only at that point is it diagnosed that Tigris may have one hip which is dislocated, or maybe both. The challenges for us is that when the child is over the age of a year, that child needs significant surgery to put that hip back into joint, and over the age of 2, the child needs to have the cuts to the pelvis and cuts to the femur in order to put the hip safely back into joint, and it's big surgery. So we've been working for a number of years now to try to raise early recognition for children with dislocated hips. And one of the huge issues for us is, how do we diagnose these children? Another hugely common condition we see is club foot, but a child who's born with a club foot, where the foot is twisted inwards, is identifiable by anyone. A child who's born with a dislocated hip, it's hidden, and you can't see that hip is dislocated unless you have the specialist knowledge on how to identify and examine that child. And the problem is, if that child's not identified early and they start to walk with a limp, then they need big surgery. So how do we do this? So we've been working with different organisations, but the primary organisation who's been helping us raise the awareness has been SAWBO, Scientific Animations Without Borders, and actually with their help we developed an animation. So the process in developing the animation actually was fun. As an orthopedic surgeon, I'm used to spending my time in the OR, but Barry and Julia came out to see our work in Ethiopia, and I think one of the key things is the cultural context and the issues that we face and the patient population that we have the privilege of caring for. And so they were able to come to meet the children who we're taking care of, and to get a true understanding about what it means to have a child with a dislocated hip. What is the medical treatment for this, from doing an ultrasound scan for a child, and how you do the physical examination, and what is a Pavlik harness when we put the baby inside the sling, and what does it mean to have the surgery. So they had the initial background, and we had this relationship where we could easily communicate online. And then, in an unfamiliar way, we started developing this storyboard, which I'd never been part of a storyboard, but it was fun to actually have the ability to work through trying to understand how best to put this together. And it was a very easy going to and fro on email. Storyboards were a rough sketch, and then they consolidated down to an animation. And to see that develop was exciting for me, to actually have that becoming a reality. To actually work with them was easy, it was enjoyable. It's a long process. It took probably the best part of a year to have this being put together, and there's a lot of editors and re-editings of things. But the joy of being able to do that was bringing it into a cultural context where you can go online and there may be some videos which you can try to use, but the problems with them is they don't necessarily capture what you're trying to show as far as the medical situation within the country. And it means that you can hone it down for the situation you have, the opportunities you have to care for these children, and the facilities are available. Now, that animation process is one that I think translates so well to the cultural context we have at the moment. So it can be translated into multiple different languages, but the benefit for us is that via a very pictorial way, we can show a child who's born with a dislocated hip, where both legs look the same. You've got a beautiful child who looks completely normal, but by examining the child and looking at the differences in that child's leg lengths, by testing to see if that child's hip can slide in and out of socket, by a very specialist surgical examination, you can find out if that child's hip is out of joint. Now, the animation has helped us portray that in a way that we haven't been able to show through pictures. It hasn't been possible to show through a slideshow. It's a 4-minute video that takes the child to identify the problem and to show the physical exam. And that for us has been huge. We've been using it primarily for midwives. We spent some time looking to see how we could target the most effective group of healthcare professionals. Now, we looked at our last 200 children. Every week, several children are coming through to have 3 hours of surgery to put the hip back into joint. Many of them, if it's both hips, will come back after 6 weeks, and then they will need another 6 weeks in a cast. So these children are in a big body jacket for 4.5 months, having had 2 big surgeries. One of the challenges that we have is to identify the healthcare group who can help us find these children early. Now, around the Addis Ababa region, where we know 70% of our children come from, the pediatricians will only see a few of those children. The orthopedic surgeons will only see a few of those children. But the midwives will be delivering the vast majority of these children in government hospitals and healthcare clinics. And we've been working closely with the Midwife Association to teach them how to identify these children. Hone is our specialist midwife coordinator, and he's been using the SAWBO animation to teach individual midwives on a one-on-one basis, and by doing so to show them some slides about what is hip dysplasia, what does it look like to have a child with a dislocated hip. But by showing them the animation, they can capture in the space for a few minutes, they can really grasp the problem and get that initial understanding about how to diagnose that children and do the physical exam. After that, he's able to take the midwife and to show them the physical exam, having used a special baby hip model where they can do a practice, and they can really understand the problem and how to find these children. So the animation for us, it's a way to really capture a complex problem, distill it into something simple, and in a way that the healthcare professionals can really understand it and find these children early. It's been a key part of our work of early surveillance. You know, the work is going on. We're starting to work with the Ministry of Health and 2 of the biggest government hospitals to develop an ultrasound screening campaign for girls born with dislocated hips. And the combination of working closely with the Midwife Association, working with the individual midwives to really foster that goodwill for them to actually understand the problem, and then to have the ultrasound examination, we feel the sensitization through the video as well as the training is going to be key to success. It's been a bit of a journey for us. It's got a 3-year journey. We're getting closer to a point where we're getting these children early, but our dream is a little Tigist who's born with a dislocated hip isn't operated on age 4 years of age, where she needs 2 3-hour operations, but then she's not operated at all. She's seen at 3 months of age, where she can be put in a Pavlik harness, a special sling holding her hips in a comfortable position, where the harness is kept on for the next 2 to 3 months. She's at home, and she's in a place where she's in a home environment, and no big surgery is needed, and she develops completely normal, perfect hips that will serve her for the rest of her life. So that's our dream, and we're just very grateful and excited to be working with SAWBO to take one step further to make that a reality.